Yes, sir. We are live on Facebook. Over to you.
Okay, thank you very much for everybody for joining. It has been a great pleasure to invite our wonderful faculty and a panel discussion for the cardiovascular disease risk factors in India. The main purpose of this panel discussion is to discuss how the risk factors in India are increasing and what we can do to prevent the cardiovascular problem in India. So this is a panel discussion. We are going to ask many of the experts to talk about what are the different ways that they are approaching this problem. And I want to welcome and thank all the faculty members that have decided to join at different hours in the different parts of the world. Today, the first thanks I have to give to Dr. Steve Nissen, who is my mentor and who has been the chairman of cardiology at Cleveland Clinic for several years. And now I work as a chairman, but Dr. Nissen is still our mentor, and he is the chief academic officer for the HVTI. He does not need an introduction in this field, but he has done incredible amount of research and work in atherosclerosis, including imaging of the atherosclerosis in the coronary arteries with intravascular ultrasound. He has written several seminal papers in atherosclerosis research, regression of atherosclerosis, prevention, and he continues to be very active. He is today, right now, in the hospital. This is 6 o'clock in the morning, and he is seeing patients in the intensive care unit today. So you can imagine that how involved he is in the clinical care. Thank you, Dr. Nissen, for joining.
My pleasure.
Thank you. And I'm also introducing Ramesh Kapadia for disclosure. He is my dad, but he has been an active cardiologist for the last almost 50 years. And he has been practicing preventive cardiology as well as clinical cardiology for all these years. His passion has been to have a secondary prevention similar program to Dr. Dean Ornish that he had started. Is called the Universal Healing Program. And he is implementing this for several years. And there are several different books and internet-related information that he has on this particular program. I also want to thank Dr. Manchanda. Dr. Manchanda, as you all know, has been very active in the Indian academic world. He is the department head for the AIMS for several years, 36 years, many scientific publications. And he is also very interested in the reversal of the heart disease with meditation, diet, and exercise. And he's also running a heart reversal camp in India. So he has been awarded Padma Shri by the President of India in 2004. And again, thank you, Dr. Malchanda, for joining us for this panel discussion. And thank you. And I want to also thank Dr. Narsingan. Dr. Narsingan is our vice chair for the Lipid Association of India. He is a very prominent, active preventive cardiologist who is working on many different areas, mainly for the consensus document that we have published for the Indian practice. And this is very important because what we are going to talk about today is how we customize or how we treat Indian population. He is a great teacher and also a great academician in India. So thank you again, Dr. Narsingan, for joining us. And I want to thank our sponsor, Mr. Nath, who has been also passionate about atherosclerosis research and atherosclerosis in India. I've been working with him for several years. And thank you, Mr. Nath. With that in mind, I just want to say a few words. So this is a interesting paper from Dr. Padmavati that a lot of people know. She's a very prominent cardiologist. She was a very prominent cardiologist of India. And in 1962, she published this to say that the atherosclerosis, first of all, the atherosclerosis research needs to be done in India, and epidemiology of cardiovascular disease is not well studied and needs to be studied more. But the information that they had from the autopsy studies showed that in India, the atherosclerosis was actually a little bit less than in European population. So now we are talking clearly 60 years ago. But from 60 years ago, now what has happened now? This is an important part. So we started out in a positive note 60 years ago, if we believe in this data. And if you go to now, so this is a paper that is published in JACC 2016 data. Still, if you look at the number of people at 100 per 100,000 patients, it is still somewhat less that if you look at it that compared to United States. However, if you look at from 1996 to 2016, the numbers are increasing in India, whereas the numbers are decreasing in United States. And of course, the population of patients is very large in India. Therefore, the overall impact of this atherosclerosis increase is very, very high. If you look at the total number of deaths from cardiovascular disease in India, is almost 1/3 of the total deaths in India. Ischemic heart disease is 1/5 of the deaths. So this is a very important problem in India. And remember, the Indian population compared to everywhere else in the world is younger. Its general population is younger. And if you look at the risk factors, the typical risk factors exist. The diabetes, hypertension, smoking, obesity, and they are all on a rise in India. If you look at the prevalence, so this is again a little bit old data, a decade ago. The national database for prevention for diabetes prevalence was 8% and hypertension was 27%. So again, very large numbers. And 20% of the population between 15 and 49 was estimated to be overweight. So you have to remember that these are young people. 20%, 1 in 5 is overweight. And smoking is also prevalent in India. So if you look at it, 11% of the adults in India are current smokers. And this is just to say that this is all over India. It is not necessarily in certain parts of India, but hypertension and high cholesterol both are very prevalent in different parts of India, particularly as you can see, in the south and the northern part of India. Important point to make during this talk is to say that what are the gender differences, male versus female. And if you see here, it is very clear that the number of cardiovascular disease per 100,000 patients, again, the number is very similar for the men versus women. The projection in 2030 is that at least it will be stable in India over time, the cardiovascular disease. And ischemic heart disease also has been projected to be stable, and hopefully we can decrease this number over time. Gender differences are important to keep in mind that, again, if you look at the dietary risk, blood pressure, cholesterol, all are very, very similar between men and women. The smoking is less. So smoking is 25% versus 11% men versus women in the people who have ischemic heart disease. And these are the basic things that I just want to highlight, that the AHA's checklist says that be active, be healthy, decrease your weight, learn about cholesterol, do not smoke, eat healthy diet, keep the blood pressure controlled, and learn about sugar and diabetes. So this is a very simple thing that the AHA has put together. So with that in mind, I want to now stop sharing my screen and then ask questions to this distinguished panel. I want to start asking with Dr. Nissen that, Dr. Nissen, you have been working on this atherosclerosis research for such a long time. For the doctors and the population, what do you think are the most important environmental and familiar risk factors, and especially for the Asian population, that they should learn and understand?
Well, there are two things that come to mind. One is that around the world, LDL cholesterol, the lifetime time averaged LDL cholesterol, is a very powerful predictor of the development of atherosclerotic disease. That is why I have advocated, and I know the senior Dr. Kapadia has advocated, earlier intervention, because if you wait till somebody is 50, 55, or 60 years old with a high LDL, they've been exposed to the elevated LDL for many decades. So that's clearly a huge issue. But in India, there is another issue that comes to mind, and that's the problem of insulin resistance. We know that in the Indian population, that just the slightest obesity, particularly abdominal obesity, a little, tummy bulge, and the incidence of diabetes starts to go up very rapidly. And that insulin resistance in many ways is driving atherosclerosis. And so I think body weight control is probably as important as anything in India. And it's one of the hardest things to do, because as societies become more affluent, they eat more calories. And as they eat more calories, they develop increased obesity. And if it's the pattern of abdominal obesity, then it's associated with very low HDL, which we see in, certainly in populations of the United States of Indian origin. And I'm sure that's what's seen in India as well. Very low HDL, high triglycerides, and the early onset of atherosclerosis.
No, perfect. Yeah. And Dr. Malchandra, you have been involved with training of so many cardiologists in India, and also learning about atherosclerosis patterns and treating the ischemic heart disease. What do you see as a trend over so many years that you have been practicing of these risk factors and how they pan out in India? What is your insight into this?
Well, as you said, Samir, the risk factors, unfortunately, are increasing rapidly in our country, and that's why the disease is increasing. I think the commonest risk factor that we see is hypertension, which of course is the most prevalent risk factor for stroke also. And although there are no really studies to show how much has it increased, a few studies in the same population have shown that it is increasing rapidly. About 1/3 of the population, adult population of India, is suffering from this, and there seems to be no stop. It's increasing now. Again, related to unhealthy lifestyles and all. So I think hypertension remains the number one cause. And the problem of hypertension in our country is that majority of the people are not even aware of this. It's a disease which most of them are, it's a disease which has no symptoms. People are not aware. One of the surveys done, Dr. Narasimha will talk about it, that about 30% of the people who were not aware, they were randomly sort of blood pressure was taken. About 1 million people were checked in one day, and it was found 30% of them had this hypertension, and most of them were not aware. Even if they are aware in our country, they don't take the treatment. And the level of optimal treatment is very, very poor. It's less than 10% in the rural population, maybe 20% in the urban population. So even if hypertension is a cause, but it is, I think it's a leading cause. The second cause is, of course, diabetes. We have the diabetic capital. Again, it's increasing. Dr. Nissen mentioned about the metabolic syndrome and the central obesity, very, very common. Again, it's rapidly increasing and all that thing. I think the third factor is level education. It's been clearly shown in many studies now, the global burden, and the Pure study has clearly shown the level of education really matters. The socioeconomic status also matters. That's not on our hands, but I think that's a very, very important cause. The third cause I will call, which is really is smoking or tobacco use. Well, fortunately, it has come down from 35 to 25%, but it's still very, very high. About 1 million lives are lost. And the so-called smokeless tobacco, chewing tobacco, it seems to have increased really, and the smoking might have slightly decreased. So it is still very, very high. as compared to any other country and all. And again, this is a very important factor. The fourth factor, which I think, which is not highlighted, is stress. Mental stress is a very, very important factor that includes depression, anxiety, and all. And very high incidence of depression, maybe about 30 to 40% of the population will be suffering. And this is also increasing. And I think this is not stressed. And I am a strong believer that stress is a very, very important factor. And that's why I think I have failed in tackling this disease, because we all know that coronary heart disease is a lifestyle disease. Now, lifestyle is a complex phenomenon in which we have life choices like smoking, diet, exercise. But I think there's a third factor of mind-body interaction, which really leads to our behavior changes and stress. And stress is a very, very important factor. I think it is coming to prominence not only for coronary heart disease, but hypertension and diabetes also, because once we are in stress, the hypothalamus pituitary axis, neurohormonal axis is stimulated, and the autonomic imbalance, and that causes all these cardiometabolic diseases and all. And therefore, I think why we might have failed in controlling it, because we have not taken care of this so-called the behavior changes or the stress changes. And therefore, I think this is very important. People are aware that exercise is good, still they don't do it. They know that diet is bad, still they don't follow. I think the behavior changes are very important. That's why I think the role of mind-body medicines like yoga may be important. A lot of data now, which is accumulating, that all the risk factors, even inflammation, even atherosclerosis reduction may occur with this, and even in cardiac rehabilitation, it has been found to be very useful and all. So I think stress is the important factor. It's been neglected. Lack of exercise, again, it has been now noted that sedentary habits are increasing, and poor diet. As Dr. Nissen said, the diet is becoming really very, very poor. If you see any part of the urban populations, the only thing which is thriving are these restaurants or the what we call dhabas, or the food. And they serve terrible food. They serve trans fats, which is, we know it's a poison. They serve refined foods, which you know is a poison. They serve a lot of salt also. And many of those products will not be approved anywhere in the world because they have so much of fat and so much of salt. It's being done. So I think there's a host of factors which are responsible, but a lack of education and stress, I think, has been completely neglected. We found that if you can control the mind body, not only you can control many of the risk factors, but they are more compliant with also the drugs and so on and so forth. So this is some of my observation. Unfortunately, they are all increasing, and slight decrease in smoking is there. This is because of the very high cost and several other measures which the government has taken, but still it is very phenomenally high. It's more than 25% of the population who is smoking and all. So I think there's no surprising that the disease is increasing, but I think we might have approached it from a wrong perspective. We have not really looked after the mind, body, or the behavior. That's why we are failing. We have prospered quite a lot in management. You see, both interventional, non-interventional procedures, the drugs. But I think one part we have forgotten is how to change the behavior. And there, I think something more is needed, and where mind-body medicine techniques may be useful.
No, thank you very much for your very insightful comments. And I think this is really the main important issue, that even though a lot of people understand that this is the problem, there is no real easy solution that people are able to find. The main reason why they are not able to find the solution is debatable, but it could be that either the education is not right, priorities are not set right, because maybe they just are not enough educated, or they don't have health as a priority. And this is where I think, in at least the outside perception is that we are missing a big opportunity, especially in a young country. So let me ask Dr. Narasimhan, who has been, as I said, the vice chair of our Lipid Association, that what do you think, Dr. Narasimhan, are the main challenges for the primary prevention that you see in India?
Thank you very much for raising this question. I think I should tell you that we have started with the introduction about atherosclerosis. It is mandatory to talk about this atherosclerosis. I need to tell you that atherosclerosis is a preventable disorder. Most important. Way back 1933 in Arteriosclerosis journal, there was a mention about atherosclerosis. It is highly impossible to create atherosclerosis without LDL cholesterol, without the remnant particles, to create an atherosclerotic process in an experimental animal. That is most important data, which got published in 1933. From that time, we had been probably fighting with this particular pathological process. A number of risk factors have been identified. Some of them are not even identified. Non-traditional risk factors are also operating. And has been rightly pointed out by Dr. Nissen, I think the cholesterol probably is again very, very important even in our country, apart from the hypertension which is detected by Dr. Manchanda. I think hypertension, nearly about 29.8% of the population in the country continue to suffer from hypertension. There are separate segment of persons who do not go for any consultation, go undetected. Again, another big chunk is there. And not only that, we try to probably keep the level as 140/90 as a cutoff point for treating blood pressure, whereas it is different when compared to American Association recommendation, like elevated blood pressure, stage 1 blood pressure. If you see 140/90, already Americans have created that as a stage 1 hypertension. That means it's very, very important to identify such group of people because there are enough data. Mumbai cohort study, which had evaluated the problem of prehypertension and its link with ischemic heart disease mortality as well as stroke mortality. It's a huge study. I think people are forgetting about our own study in India, and that has probably reached the important message that we need to probably identify those people with prehypertension. Studies have also shown people who have less than 140/90 or having much risk for problems of developing a cardiovascular disease when compared to people above 140/90. So these are all certain things which need to be identified and tackled. So that means you need to concentrate on one, health education. Number two, the physician should come to know what is important, or the healthcare provider, or the persons who are actually delivering healthcare at the primary center level need to know about the implications of hypertension with the cardiovascular disorders. As far as the lipid is concerned, at least about 79% of the population studied in our country through ICMR in Dept study clearly denoted that there is a problem of lipid disorder, either triglyceride or HDL low, or a small dense LDL cholesterol going up or LDL cholesterol going up. And that's the situation. 7.2% of the people having LDL cholesterol, and about 33% of them are having triglycerides. So our lipid pattern is entirely different. Probably it is related to the Asian Indian phenotype, which is responsible for producing insulin resistance, which is high, hyperinsulinemia high, fasting blood sugar goes up, or impaired glucose tolerance high, obesity, particularly the abdominal adiposity, in addition to the atherogenic dyslipidemia, whether characterized by high triglycerides, low HDL, increased proportion of small dense LDL cholesterol and of OB particles in that. I think this particular pattern of dyslipidemia puts many patients for an early coronary event before they could develop diabetes. It is very, very important. The stage at which we see patients with obesity or with the metabolic syndrome, we identify this atherogenic dyslipidemia, but we don't treat many patients. They try to escape because they are all healthy. They think that they are healthy. But when we look at the reports, we know that they have an abdominal adiposity. They have waist circumference very high. At the same time, the atherogenic dyslipidemia started. And that is the stage at which we should intervene and then try to tell them what is important to save their lives. Very, very valid information, what I thought I should share, because this is most neglected area. If close observation of those people who are coming under the category of metabolic syndrome, they have seen that many of them develop ASCVD or succumb due to sudden cardiac arrest, or they could develop diabetes. It may take a number of years for them to develop diabetes. From pre-diabetes to diabetes may take 5 years, may take 10 years also, depending on the family history, depending on the genetic predisposition to develop the problem. I think that we need to catch those people who are obese. We need to catch the people who are having metabolic syndrome. We need to identify the lipid abnormalities. Apart from the elevation of blood pressure more than 130 or 85, which comes as a criteria for metabolic syndrome, and the fasting blood sugar which is going up, or IGT which is going up, because the segment of people who have the IGT or IFG are really vulnerable people to get atherosclerotic cardiovascular disease. That point has to be emphasized not only to our colleagues, our junior colleagues. It should be started at the undergraduate level. What is important to recognize such individuals? It's not enough just to tell them how to treat coronary artery disease. We need to probably identify these risk factors and tell them what is important for them to take it home to the patient's level, to the patient's relatives level, the school level, the college level. And at the time when these people are seeking advice for getting entry into some job or leaving the country to get some other job, they need to be probably screened for all these abnormalities. Only then it is possible to control the disease. These are all the challenges what we face. Number of challenges, a number of points which need to be tackled. So tackling obesity, tackling metabolic syndrome, identifying atherogenic dyslipidemia, tackling the hypertension, keeping the levels 140/90 is not good. I think I always try to favor the SCCHA guidelines, keeping the level less than 130/80 for all people, irrespective of the underlying complication, is very, very important. In addition, we should also talk about the psychosocial factors, which had been highlighted by Dr. Manchand, very, very valid information for depression, anxiety, and the lack of what I can say, lack of exercise, physical inactivity. Most of the time they confine themselves to their chair and try to enjoy the TV, take high dense calorie foods. Urban population are entering into a lot of what I can say, the so-called faulty food habits, which had encouraged them to get into obesity. I think these are the very, very important points what I thought I should share. In addition, I would like to tell you that the Interheart study, which are concentrated even in South Asians, Indians were also included in this particular study, where they've identified 9 commonly occurring reversible cardiovascular risk factors. And out of this, only the ApoB1 ratio had come out as the number 1 risk factor for pushing patients for atherosclerotic cardiovascular in the form of myocardial infarction. The second one is the psychosocial factors, then the third one is the physical inactivity, and the fourth one is hypertension, fifth one is diabetes. So these are the things. Overconsumption of less consumption of fruits and vegetables. Again, another important thing. Whereas the consumption of alcohol, though it considered to be protective for other people, it is not valid information for Asian Indians because increasing problems due to alcohol consumption have been identified. I think these are all the challenges what we face. So I think these are the messages which I thought I should share it with all those people who are watching this particular program.
Thank you very much again for very insightful information. And I want to stress this part that number 1 is that we identify the risk factors and how we identify the risk factors. Second is that how do we implement the lifestyle changes? And as Dr. Malchanda mentioned, and you mentioned, that the awareness is one part, but the motivation, the self guidance to say that how we are going to implement these changes has been a challenge. And we constantly face this as a challenge. So I want to ask Dr. Kapadia to say that how he sees how does the Universal Healing Program that he implemented helps with the implementation of reduction of or managing these risk factors.
Very frankly, I feel like a fish out of water amongst these academicians who have got such a wonderful data. I have no data. I'm so fortunate that I added a program which is now come to known as Universal Healing Program to our medical management, a standard medical management. And I found one most important thing by adding the program, that it gave the participant inner strength to change his lifestyle. Whatever we advised was able to put in practice. Let me tell you how I came to understand the Universal Healing, how the name came, Universal Healing Program. I started a program of diet, stretching and relaxation exercises and progressive deep relaxation. But when our participants, they did this program twice a week in a group, and the people who are helping me to conduct this program, they told me that these participants now tell me that they feel much better and their standard medical management is now more efficient. But the one thing that was really very interesting was that the spouses of the patients who were taking part, the spouses said that now my husband has got less anger, he's less hostile. So I said, that is something wonderful. This is not only helping the lifestyle changes and all that and making them feel better, but he said that this is it's affecting the whole individual. So believe me or not, when I thought of it, and when I was sitting down with the people who are helping me to conduct the program, at once I said that this program now affects the whole individual, and therefore it is a universal healing program. Let me tell you, the listeners, my friends, that the word universal came to me from the heavens, only 1 second only. And every activity that I have done is an inspiration from inside, because I've not been a very industrious doctor or industrious reader or industrious, in many ways, not fit to be in this conversation. Only part that I have to tell you that whatever you say, the strength of the individual to make lifestyle changes is most important. Therefore, I recommend my program very strongly. And that program now is available on our website, completely free to download. And our publications on that program are also done by Guardian Press, Navjivan Publishing House. They're also available free to download. And the whole thing is, let me tell you with all modesty, that I'm so lucky that Gandhi has figured in my life right from the time when I was 3 years and 5 months old, when I was in his lab. And since then, somehow or other, everything that occurs is connected with him. That program started on 2nd October 1991. I did not say that, but it was Sunday and it was convenient for the chief guest whom I was inviting. So it came on 2nd October. So now this program is a comprehensive program to strengthen the medical management, but what would you have? And
I understand. The question is that what is the important, unique part of the program that helps people to organize the system? So what is the most important thing that you are doing right now?
Yes, now the light stretching and relaxation exercises that we teach, and then they go into progressive deep relaxation. The old word is savasana. And when they go into savasana and become one with their breath, the breath is same for everyone. And therefore, that gives them inner strength to change the lifestyle that I said. And that savasana is the cream or the most essential part of the universal healing program. So I tell you that whatever you say about the lifestyle changes and implementing it, practice of savasana will make it possible. And it also is helpful in primary prevention. It's helpful in secondary prevention. So I am in love with that program. I have been in practice for the last 55 years. And I respect my training in UK, US and everything. But this came all of a sudden. And it came all of a sudden. Let me tell you how.
Yeah.
A doctor from USA had come to lecture on, these are all subjects which are medicine and non-violence. Can you believe it? The subject of the talk, Larry Doshi was going to deliver that talk. Larry Doshi is a seminal thinker of USA. And he had come to India to deliver a talk on medicine and non-violence. And nobody was prepared to listen to him. And let me briefly tell you that I got quite impressed with his talk. And then he introduced me to this young Dr. Dean Ornish about the program. And when I saw the program of Dr. Dean Ornish, I was impressed how he treated 40 patients of his with triple vessel disease were getting well without intervention. And that is the thing that I started. And in the process of starting this program, which was all known, I came across this inner strength to savasana, and I called it, and then I saw the changes in my participants, which was wonderful. It's no small thing to have that inner strength to change the lifestyle and to feel oneness with each other. And therefore I said it's a universal healing program.
No, that's wonderful. So this is a great segue to say that we have this wonderful effort to give inner strength to people. How we organize the delivery of lifestyle changes, but at the same time, we also want to know that what are the efforts ongoing in India right now. Maybe Dr. Malchanda, you can highlight some of the efforts that are ongoing right now in India on the primary prevention front?
Well, India, is a large country. There are a very large number of people who stay in the villages and all, and they are not having any medical sort of aid, etc. But Indian government has been doing for quite some time now. There is a national program which is going on for 15 years. This has been taken over by National Health Mission. And this is a program of control of 4 lifestyle diseases. That is cardiovascular disease, that is diabetes, cancer, and stroke. This is called the CS program. And this is going on for quite some time. What this program is doing is that it is using the primary health workers for early diagnosis. There are several projects which have been done in several districts have been done for early detection and the prevention. And then they also talk of the treatment for this thing. But India being a huge country, you see, it has been implemented in many places. Research is going on, but it will take quite some time. Another program has been taken up is the Promotive Health Program. And this is using the alternative systems, as Dr. Ramesh Kapadia said very well, that deep relaxation, the role of yoga, meditation, is being also tried for health promotion. You see, this I call it as the primordial prevention. It's not even primary prevention. So there is a project in which this Ayush Department of Yoga, in India we have a Yoga, Ayurveda, Unani system. This has got involved, and this is now combined with this National Control Program of Cardiovascular Disease. So I think that this would have a great effect. They are actually trying to promote the health. And once health promotion is there, then all these positive habits like exercise, the diet control, stopping smoking, etc., come and all. Ayush, I will agree with Dr. Ramesh Kapadia. It gives you inner strength, the meditation or the deep relaxation I was saying. There are hundreds of studies now that functional MRI imaging shows that our willpower increases. We become positive and we are able to follow these lifestyles. You see, it's very easy to say that change your lifestyle, but majority of the people don't bother. Even after a heart attack, they don't change their lifestyle. But I would agree with Dr. Ramesh Kapadia that if you can change their sort of mind or make their mind strong, which can be done with a universal healing program and also by meditation. A huge number of studies are there. We also found in our studies, I have been treating patients with so-called meditation, which is quite similar to Ramesh Kapadia, that they follow what they are told because the mind becomes positive and all. So this is a very good program, and this is being tried by the Department of Ayush in India, and hopefully we will have some good results and all. Because I think for primary prevention, you have to involve the number of doctors is small. You have to take the primary health workers. You have to involve the other systems also. And let's see the results. So this has been combined recently. Then there are programs for the treatment. You see, they are giving cheap treatment to the remote villages, etc., and all, and trying to find out through the health workers why these different sort of proformas which are available, simple diseases like diabetes and so on and so on. Not only government of India, but there are non-governmental organizations also who are trying to increase the capacity building. For example, we have the Public Health Foundation of India. There's a Center for Chronic Diseases who is helping quite a lot in capacity building of these workers who will be helping in these. They are also using the digital media. So there are a number of programs using these mobile phones, and they have been very successful in the early detection and in the treatment and so on and so forth. They are using even the primary health workers to give medicines in simple diseases. They have simple approaches in hypertension, dyslipidemia, etc. So I think these are the programs for detection and early detection and the treatment and the management and all, and of course health education. Because it's a vast country, as I said, you cannot have that much of manpower. Therefore, I think the primary health workers which are available are being used and all. The program is going on, but being a vast country, I think it has to be encapsulated throughout. And there's some research is going on to see which will be the best method. One of the best, which looks like is using the digital technology, that is smartphone. A number of projects have been done, and hopefully they will be implemented all over. So government is doing, but I think it's not enough. The individuals have to be changed. And as Dr. Ramesh Kapadia said, we have to energize them themselves. We have to empower them themselves. And one of the best methods is by yoga meditation, which he is also using. And I think as yoga is becoming very, very popular in our country, I hope that this will help us in controlling these diseases at a very, very early stage.
Okay,
Wonderful.
I had a comment and then a question, if I could.
Yeah,
Of course, Dr. Nissen.
Sure. The comment is that these risk factors, there's quite a bit of crosstalk. That is, they co-associate. And, from my perspective, the problem of insulin resistance is interrelated to so many of the other things that we see. Obviously diabetes, but hypertension, very closely associated with insulin resistance and the atherogenic dyslipidemia. So, from my perspective, in primordial prevention, it might be really useful to address the obesity problem. But here's my question. There's been a lot of talk around the globe about the poly pill. And I want to know what my colleagues from India think about this. I've made comments about its utility in the US population, but what about in the very vast population of India? Does it make sense to you? Should it be developed?
Yeah, yes, there are three trials, primary prevention trial with the poly pill, if I add it up. And these three, this has been published recently and all. They have done it with aspirin, without aspirin also, using 3 drugs without aspirin. And they found that with aspirin, the reduction in cardiovascular events is marked. So I think there is a role somewhere in the primary. Secondary prevention, I think there's no doubt about it, that poly pill works. But even in primary prevention, there are 3 studies which have been done in India. They have been published in Lancet some time back. And they have shown that, yes, it is useful, especially if you combine with the aspirin. Aspirin, I know, has a doubtful use in the primary prevention, but these studies which have been published in a number of populations in India, and these studies show that it is useful combining these 3 drugs in small. Statins is one of them, but there are other drugs also in that, antihypertensives and so on and so on. Aspirin is also one of them, which reduces myocardial infarction and stroke, which is surprising, but it has been published. So I think there may be a role, but I think it has to be done at a larger scale. Yeah.
No, I agree with you. And Dr. Nissen, as you can imagine, the cost is a very important part, and the compliance. So there is, although in United States there may be a difference, in India, this is a very important part. And so the poly pill has some, at least in my mind, some role in Indian population where the cost as well as the compliance is very important. I want to ask Dr. Narasimha to say that what is the LDL, because you do a lot of research on this particular part, what should be the goal for the primary prevention for the LDL, and who should we treat and how should we treat, what doses of statins, if at all, for primary prevention? What is your take on this?
If you look at the data that is available with us as far as the primary prevention trials are concerned, you plot it, it probably touches about 55 milligrams for primary prevention. All those trials, right from FIRST-COV, SAFS-COV, all those trials, including Jupiter study. Jupiter study was a study which was conducted in people without diabetes, without baseline cardiovascular disease. They were all given only 20 milligram of rosuvastatin, followed up. Remarkable beneficial effects were identified, like 50 milligram reduction of LDL cholesterol in that particular group that resulted in about 48% risk reduction in subsequent years. That shows that there is a definite role for statin therapy, particularly for primary prevention therapy. And we are going through all those data which are available in the past also. Definitely that helped people who are elderly, like the CAS study, or people who had come out with a high risk of cardiovascular disease. They were all given statins, either bovastatin or simvastatin. Even the heart protection study, which concentrated not only on secondary but also primary prevention strategy, diabetes, type 1 diabetes, type 2 diabetes, with risk, without risk, everybody got benefited. In fact, heart protection study did not identify the ideal treatment goal beyond which the benefit was not obtained by these individuals. But that shows that there is a definite benefit, number one. Number two, even for heart study, people with diabetes would like to prevent the cardiovascular disease. they were given only 10 milligram of atorvastatin compared to the placebo. There was about 33% risk reduction within a matter of 3 years. The study was closed within a matter of 3.2 years. To give the benefit to the placebo arm also. There lies the wonders of this treatment, particularly the lipid lowering drug, statin, and wonders, not only in diabetes, but also without diabetes. Even people with hypertension, they're all given only 10 milligram of atorvastatin in ASCOT trial. It has shown beneficial effects in the form of reduction of cardiovascular events. Again, emphasizing the role for lipid lowering in those people who are at a high risk as a primary prevention strategy in those people who are having a high risk. We need to identify the risk, what's important. So in the United States, probably you follow the ACC-AHA calculation. And of course, in Europe, they follow this score. And we know about the Framingham risk score. You have to multiply by 1.2 or 1.2 for males, for females, all those confusions. What happened to our Lipid Association of India? We had gone through all evidence that were available at our disposal. We got it, we summarized it. We have come out with a good algorithm where we have identified the risk factor, risk enhancing factors, and then moderate risk, non-conventional risk factors. Take all these three into together and then make it as low risk, medium risk, high risk, very high risk, extreme risk. In 2016, we stopped with the very high risk. Now in 2020, we have added extreme risk group. That extreme risk group already patient developed coronary artery disease with one high risk feature, or CAD with the polyvascular disease, recurrence of attacks of stroke or other things, in spite of the patient having a low levels of LDL cholesterol is 50, but is getting another attack. That means a polyvascular disease or recurrence of stroke or recurrence of ASCVD. Such people are categorized as a category B of extreme risk, where we advocate only 30 milligram and less than 30 milligram as a goal for this group. Whereas category A, we still keep it as less than 50. For very high risk, less than 50. For high risk, less than 70. For moderate risk, less than 70. Like that, we have categorized. Everything appears in one simple sheet where we have identified all these factors. If somebody downloads it and keep it on the table, it's very easy to identify. Of course, we don't have a level of evidence. We don't have class of recommendation for us to proceed further. But this is a very simple information which covers almost everything, including lipoprotein little a, which is almost a totally forgotten lipid parameter in the country. In spite of the fact that LPA levels are high in Indians as a genetic problem, which probably is one important factor associated with the familial hypercholesterolemia. Lipoprotein little a is the one that probably responds to recurrence of events in those people who are getting another attack. So we have seen, even now, in my own clinical practice, I'm seeing people who are getting more than 100 LPA apart from getting a heart attack. So we see such people also. I think we need to have certain amount of recommendation from some academic bodies. What we now recommend from Lipid Association of India, we hope that is useful for Indian patients. We hope our healthcare providers will take it forward, implement it in their clinical practice so that things becomes easy. Instead of calculating and then the risk this much, less than 7.5 to 10 to 15% like that. Instead of calculating like this, getting more confusion, because either we underestimate, I'm not blaming anything, because it is useful for US citizens, no problem at all. For the various ethnic groups, I think they're all suffering. They may not be able to implement it in their own practice. So I think that has to be evaluated properly. What we did in 2020, an updated version of the atherosclerotic cardiovascular stratification, is very easy to follow and very easy to implement in clinical practice.
Wonderful. And Dr. Nissen, I want to just check with you, because you are very involved in this particular topic because of Lp(a), as well as the how we should use the statins for primary prevention. What is your clinical take? You know, if a young person comes to you and says that the LDL is 120, what do you suggest?
First of all, I am really pleased to hear that you have very aggressive LDL targets in your recommendations in India. I have disagreed with the ACC-AHA recommendations, which say just give a statin and don't worry about the LDL. And you know, your approach, Dr. Rossinger, is absolutely the right approach. You know, that you grade the risk, but you go for very low targets. We have seen over and over again that in virtually every population studied, the lower the on-treatment LDL, the lower the risk, all the way down to an LDL of 30, which is what was seen in the Fourier trial. And in our own Glagov trial, we went to an LDL of 36 milligrams per deciliter. So I agree with you. And I'm also very pleased at your focus on lipoprotein little a, because although there is not currently a treatment available, there will be. We are running clinical trials now with 4 different companies with 4 different drugs to treat LP little a. The most advanced one is the antisense oligonucleotide. And that study is 8,300 patients. It's fully enrolled. We are continuing that study until we get the requisite number of events, and then we're going to unblind it. And it is my sincere hope that we'll see that lowering LP little a by about 80% with this drug will reduce recurrent myocardial infarction in secondary prevention patients. But here's the dilemma. If these drugs are successful and nobody knows what their LPA is, how are we going to identify the patients and treat them? And so your focus on LP little a in the Indian population is right on target. And you will see in the next few weeks a manuscript from me on a study in about 50,000 patients globally that shows what LPA levels are in various countries and regions of the world. And your focus on the problem in the Indian population is right on target. And I think the more you can do to increase awareness, the more we'll be able to help people when these drugs become available.
No, wonderful. And just to understand that in India, for the PCSK9 inhibitors and the statin intolerant people, what is the method of treating this patient, Dr. Narasimha?
PCSK9 inhibitor, one thing that I should tell you is very costly.
Yeah.
Most of our patients cannot afford, number one.
Yes.
People in whom we have diagnosed acute coronary syndrome and incidentally is found to also have a strong family history of premature coronary artery disease or death. You think about the familial hypercholesteremia, try to screen the family members, either cascade screening or a reverse screening, and you get into problems, you make a diagnosis with or without xanthelasma, tendon xanthoma, you make a diagnosis. Those patients probably may not respond to the conventional high-dose statin plus ezetimibe. That's what we do. High-dose statin, Rosu of 40 milligram plus ezetimibe 10 milligram. Give it. Instead of giving it in the sequential way, why not we give it in the first 2 drugs together? And then what the LDL cholesterol values? If it is touching less than 50 in the next 4 weeks or so, that means you are comfortable. If it is not touching, I think we should probably try to be very, very aggressive in promoting PCSK9 inhibitor on such individuals. People who are not able to buy this drug because of the cost factor, probably the bempedoic acid is now arrived in Indian market. This may help, but however, I need to tell you, there is no cardiovascular outcome data. Clear harmony trial is going on, a clear outcome study is going on. Probably you may get the details after some time. But many patients who are not able to reach this goal, in spite of having an attack, probably in spite of taking a large dose of statin plus ezetimibe, we try to give them PCSK9 inhibitor. That's number one. People who are really statin intolerant, really, it's not the question of the nocebo effect or the placebo effect or placebo effect, whatever terminology that we use, that doesn't matter. You identify a fellow who has a true statin intolerance based on the CK enzyme values, that means he is a candidate who has to probably receive PCSK9 inhibitor. So that's the number 2.
I get it.
Yeah.
Yeah. Just one comment.
wonderful.
Trying to unblind the CLEAR outcome trial in early December, and we'll report the results at the American College of Cardiology meeting next spring. So the study is essentially done, and we'll get some answers on whether bempedoic acid has reduced morbidity and mortality in this population that we all struggle with.
Now, one tricky question, Dr. Nissen. I know this is a difficult one to be not emotional about, is the calcium scoring. So when you are having the patients who are not patients, but the population for primary prevention, what do you think is the role? Because in one downside, as you know, of the calcium scoring and calcium CT scans is that it leads to unnecessary investigation. So if you are disciplined, of course, it's a great tool. But if you are not very disciplined, it can lead to unnecessary testing and investigation. So I wanted Dr. Nissen to weigh in on this because he has given a lot of thought on this particular topic to say that what should be the role of calcium scoring in detection of coronary disease, especially in the young asymptomatic patients.
Well, it is a very effective strategy for identifying risk. The concern that I have is that every week I see patients in whom a calcium score was performed. They are asymptomatic. The score is very high, and their cardiologist says, you've got a high calcium score, we need to do a heart catheterization. And then they get, they have an intermediate lesion, they get a stent, they get restenosis. I mean, one thing leads to another. And the reason I have been reluctant to embrace calcium scoring is it's misused. People also are doing it serially, and they have this belief that it will tell them whether the disease is progressing. And as some of you know, we published a paper showing that once you treat a patient with a statin, their calcium score goes up because you convert soft plaque to calcified plaque. And so I see patients who have been on statins for 5 years, and their doctor gets a calcium score, and it's high, and they're scared to death. And the study should never have been done. So you put your finger on it, Dr. Kapadia. What if we use it in a disciplined way to detect people, maybe somebody with a family history, you get a score at a young age, and it's very high, you can treat with statins earlier in life. But we have to avoid unnecessary investigations in those patients because they lead to harm. And there is insufficient discussion of that in our scientific domain. And that's why I've been outspoken about it, because I see the consequences almost every single week.
And me too, because I think every influential person in the United States gets a calcium score, and they all want a cath. And this is what happens constantly, that people want to find out. Anyway, so this is a very important thing. If you are disciplined and if you use the data in the way it's supposed to be used, then it gives it's a great test, but at the same time, it has a lot of slippery slopes. So you have to be very careful about interpreting the results, especially with the follow-up and things as you mentioned. Since we are running out of time, I want to just ask a very different question now, that what should we do maybe to Dr. Ramesh Kapadia to say that how should we have awareness increase? What should be our goal in the near future for the awareness? Which population, which people we should address this primary prevention to?
Is the question addressed to me?
Yes.
Yeah.
Okay.
So which population? So in the universities.
First of all, I'm very fortunate that I've come in contact with Dr. Narasimhan. I've already known Dr. Nissen very intimately. And of course, Dr. Manchandra, who has known all my work. And I've learned a lot during this last 10 years from Dr. Nissen. And he came to my important conference where I was I was the main person, who conducted that conference, and he gave a wonderful speech on primary prevention. So now, having heard all of you, most important thing is to bring awareness to these young people for primary prevention. And I think that our program, which is very simple, our program has only one disadvantage, that it is simple and it is cost-free. Simple and cost-free are very difficult to be taught in this world at this moment. It's very difficult. And that is the only setback of this program. But if I pray that if the intelligent people like you and many learned people like you understand the program, and it's no stamp that is not Dr. Kapadia's program. It's a world's program. And I think, because I've been in game for 55 years and now I'm 88 years of age and still very, 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 very active in second opinion practice. And I have really about more than 10,000 patients for unnecessary intervention, and they are all very grateful to me. So that all this, and the whole approach, I learned a lot from this present talk, and Dr. Nissen has been a guru to me. He has really given me a great guideline. Let me tell you the shining example of primary prevention. Shining example of primary is myself. My younger brother, only 3 years younger to me, got a heart attack. And my 4 maternal uncles got the heart attack. And then my cholesterol, when I was only 28 in 1963, one of the most prestigious hospitals of USA, PGH, attached to 5 medical schools. And my teacher was Dr. Samuel Bellet, who was a physician to the President Kennedy. At that time, he read my cholesterol and he found that my cholesterol total was 300 and my LDL was 120. And he repeated the test. And he said, Dr. Kapadia, you would seem normal weight and normal, you are vegetarian. You have been, very, in most ways, you are ideal. But this, I think, is a feature. At that time, it was not so well known how to control the LDL, because I tried to all methods to bring down the lipids, but I failed. I was very fortunate. My son, my younger brother was not. He got a heart attack all of a sudden at the age of 53. At that time, I was 56. And when he was operated by Dr. Denton Cooley. And when after the operation, he asked my brother, who is a lawyer, asked him, now what treatment I should take. And doctor very, very nicely, he said that I don't know how to write, what to write. I asked my cardiologist to write a treatment. I only operate, Denton Cooley said. But your brother is a cardiologist, so now he will take care of you. And fortunately, at that time, I had come in contact with all this new idea about the LDL and all that. And I started taking statins in proper dose, about 40 milligrams. And at the age of about 60, and when I was 75, I was getting checked up. This is before my son came to the United States. When I was checked up with a cardiologist in Atlanta, they were very interesting. Atlanta, he checked me up and I was normal. But still my LDL was high. And he said that, Dr. Kapadia, the recent evidence now says that now you make it 80 milligram, 40 milligram. I have still an Indian mind. So I said that I'm feeling so well, perfectly all right, and statins and all that. I'm taking 40 milligram. I'm completely all right. Why do you want me to take 80? He said, recent data says that your LDL should be lower than this, and that will give you assurance. Otherwise, so I said to him, if anything happens to me, then I'll take, or if I get any symptom, then I'll take 80, but I'm feeling well. And he remarked, very well, you should all know it. He said that then you won't require it. That one sentence, that if something happens to me, I'll take 80 milligram. And he said, the cardiologist, very clever in Atlanta, he said that then Dr. Kapadia, you may not require it. Since that statement of saying I'm not required, since same night, I started taking 80 milligram. And I'm taking 80 milligram even today. So that is the beauty.
No, but how do we reach out to the young people?
Let me say, I'm telling you that I'm in love with university program because it is simple and cost-free. Now, that is the greatest disadvantage of this program. But let us accept it in this world. It will one day come out very glorious, I'm sure. Larry Doshi, who actually is the father of this program in one way, that he introduced me to, is a seminal thinker of USA. And I think that this program has a future, which is going to be a great future. And it has got, and I'm again thankful to all these 3 learned participants that I have learned from you. And Dr. Nissen has been very close to me, and Dr. Manchanda also very close. And Narsingam, from your talk, you have come close to me. And I feel very happy that I agree. Conducting this very nice program. You can see that he's allowing all of you to talk, but he doesn't allow me to talk much.
I know everybody.
Because he knows that so much of talk that I want to do does not agree with the present thinking of his, which is understandable, But let me tell you again and again and again that universal healing program, and I told you why it is universal healing, because it heals the whole individual, and therefore I said universal healing. That program has a great future in primary prevention as well as secondary prevention, along with the medications and the other care and all that decided by Dr. Nissen, Dr. Manchanda, and Dr. Andersingam. And with this remark, and with primary prevention, we have got to see that this universal healing program goes to schools, colleges, and all major companies. All major companies and schools and all, they require the practice of universal healing program and understanding the thing, so they get inner strength to change their lifestyle. So that is my dream is there. I am in love with this program, and so that's why I'm telling you that this program should reach every corner of this planet. Not because it's my program. It cannot be my program. It's sent from the heavens. It's sent from the heavens, because the word universal also came without my thinking for even 1 second. When the participant told, my organizer told me that the participants are happy, not only that because their coronary, their symptoms are better, but the spouses said that my husband has lost his anger, is less hostile, is better. So that was a great lesson to me, and that you can multiply 1,000 times and understand that has the power to change the planet, Whatever we see now, something like that is going to make the great difference. And Larry Rossi is with me. The coming years are going to be different for the whole world.
No, I understand. Daddy, I got it. Now, listen 1 second. I know you're so passionate. Everybody is so passionate. This is the momentum that you raised. I truly appreciate that. I know that you feel that this is the most, and we all agree that this is a passionate plea that we want to do something good for the primary prevention. I'm just moderating for the time, so that's why I was trying to say that we want to finish on time, and that's why I was trying to restrict the talk. It is not to say that you don't want to talk or anything like that. So this is an important message. I'm trying to just make sure that we have all the points covered, and everybody. I'm so thankful. First of all of you are my mentors, and to a level where as Daddy was also pointing out that he's thankful to all three of you that you have contributed to this. My goal was just to moderate and just provide a basic insight. I know that this is one of the most important topics in the world, not just in India. That every meeting you go to, every place you go to, even every social gathering you go to, people always ask that how they can stay healthy. So this is we want to take this to the masses. We want to make sure that people like all of you, who are the experts in the field, can communicate properly to the authorities, to the right people, to say that how we can popularize the program. Different kind of programs, whatever people are passionate about is important. But this is a beginning. I know that all of you have spent your lives on this particular topic. So thank you again for being part of this incredible panel. And we will stop here. And again, thanks everybody for joining.
Thank you all. It's great to see you.
Thank you.
Thank you.
Thank you very much for an outstanding deliberation from everyone.
Yeah.
So take-home message could be for doctors who are all listening to us, that we need to really not only treat the patient with their optimum medication, but we need to also look at to their lifestyle, their mind and body, probably very, very important, which Dr. Kapadia, Dr. Manchanda is very categorically mentioned. And of course, treat to new target is Dr. Narasinghan and Dr. Stephen is very categorically mentioned. Dr. Kapadia, thank you very much for Dr. Samir for moderating it. Actually, we had so many things to discuss, but yes, time is a constraint, and because we cannot, what is called extend it for a long. I look forward to very frequently, at least such program, because there are so many area we could discuss. So surely, in the coming meetings, I'll be requesting, coordinating with all of you, and looking forward to your support to bring an awareness for extending a life, better life, and meaningful life in our country. Thank you very much.
Bye,
Thank you.
everyone.
Thank you, Mr. Thank you.
Thank
Bye-bye.
you.